is notified. We're fortunate today to have Jeff Leach from the North Carolina Office of the Chief Medical Examiner join us today. He serves as the coordinator and medical examiner trainer for the Western region in North Carolina. He'll be sharing with us his perspective, sort of on the other side of things from what we see. So, Jeff, we look forward to your talk today. We hope we get some good conversation, lots of questions out of it, and look forward to hearing about your experience in your role at the medical examiner's office. So take it away.
Thank you. Thank you, Dr. Green. Again, this is Jeffrey Leach. I'm the Western coordinator for the Chief Medical Examiner's Office and the regional trainer for the Western region. My background is my college degrees are in atmospheric science and history. I do have an associate's in EMS, and I'm probably one of the few that actually retired from EMS after 32 years. And I became a medical examiner in 2017 and got a national board certification. And when I retired from EMS, I was offered this position with OCME. So it's very good to speak with you today, and I hope I can give you some insight into the medical examiner system and how it works, and can provide some guidance in your day-to-day task dealing with decedents. First of all, I would like to start out with the history of MEs. You may not be aware, but in North Carolina, prior to July 1st, the law stated to become a medical examiner in North Carolina, you had to be a physician, a nurse practitioner, or a PA is included, a registered nurse, or a paramedic. A lot of people are, wondering why paramedics fit in, and they actually are turn out to be very good medical examiners. We're looking for basic medical knowledge. And then we have a 4-day class that we teach for the medical examiner procedures, how cases are handled, and the laws affecting deaths in North Carolina. So prior to July 1st, those were the people that were eligible. Governor Cooper, on June the 30th, in the evening, signed a law that expanded the professions that can become medical examiners. These are to include now dentists, physical therapists, and medical legal death investigators. So those folks now are eligible to become medical examiners here in North Carolina. We are always recruiting. If you fall under one of those categories, and after my talk today, you're interested in becoming a medical examiner, please reach out to me. Scott has my contact information, and I will be happy to speak with you and answer any questions about what is involved in being a medical examiner. Now, as mentioned earlier, medical examiner jurisdiction includes homicide, suicide, poisonings, overdoses, and natural deaths that do not have an attendance of a physician. And simply put, that means if a person expires and they do not have a doctor or have not seen a doctor in a reasonable period of time, and we generally cut that off at 1 year, then we will accept that case as a medical examiner case. Typically, a natural death is not a medical examiner case if the decedent has a primary care physician or has been followed in the hospital recently by hospital staff, particularly a hospitalist. So those death certificates can be signed by those attending physicians. And an interesting note for the ER physicians, um, there is one exception to that. An unattended death who dies in the emergency room and they do not have a primary care physician, the emergency room physician is eligible to sign that death certificate. However, we understand the hesitancy in that, and we frequently take that case anyway. But the emergency room physician can sign in that particular case. We also now have the electronic death certificate system. There are no more paper death certificates. Everything is completed online, and all physicians, particularly primary care, cardiology, any specialty like that, not so much an orthopedist, but any with direct internal medicine patient care is now required by statute to be on the North Carolina electronic death certificate system. So that has been in place about 2 years, and it is working out well. One of the other issues that you may encounter is an out-of-state visitor to North Carolina. And I know Mecklenburg County, I was shocked at the number of deaths, natural deaths, that occur at the airport in Charlotte. People just transiting through. So those deaths, even if they have a physician in their residing state, we do take jurisdiction over that case unless they have a physician who practices in North Carolina and has a North Carolina license. So a visitor here from California that collapsed at Charlotte Airport would be a medical examiner case. I hope that helps the nurses that are present that are working in the ER, that will give you some guidance on how that particular case would be handled. We're just going to go on to the manners of death and how that affects you. Now, this is coming straight off the death certificate. So we have the manners of death, which is different than the cause of death. The cause of death is the direct cause, like gunshot wound to the chest. And the manner in that particular case, it could be homicide or suicide. But we're going to discuss the manners. There are natural, accidental, suicide, homicide, and cannot be determined. The cannot be determined particularly applies most frequently in infant deaths. Co-sleeping occurs with the parent, and if a parent just moves their arm over the face of an infant, that can easily cause suffocation. But often we cannot determine a cause of death in the autopsies of the infants. So that's what undetermined would be. Today, especially with your conference, we're going to talk a lot about accidental deaths and traumatic deaths and the languages that we use in those instances for the cause of death. So we're going to talk a minute about traumatic deaths. I would say the terminology that we use on the death certificates is antiquated, and it's based a lot on the Old English system, the Old English medical examiner system. For instance, I'm thinking a lot of you would consider hanging death to be asphyxiation by hanging. But really it's not. We just simply use the word hanging. If someone fractures a hip, again, we will touch on this a little further later. If they fractured a hip, and it was repaired, and they did not return to their baseline and expired, we would just simply say complications of a left hip fracture. So we try to keep these terms simple. We car accidents could be multiple blunt force injuries of the head, blunt force injuries of the torso, and complications of bone fractures as well. Fire deaths, we call those thermal injuries, and often include inhalation of products of combustion. I will give you an example of that. This was one of my medical examiner's case. I had a gentleman who was on oxygen therapy and smoking, and he caught his beard on fire and subsequently went into cardiac arrest. EMS resuscitated him successfully, and he spent 4 days in Mission Hospital, and it was determined that he had an anoxic brain injury. So his cause of death would equate to be anoxic brain injury due to cardiopulmonary arrest due to inhalation of products of combustion. So I'll stop there and let everybody soak that in for a minute. It's a sequence of events. And I do not mind at all if anyone has questions and they want to stop me, while you have the question. That does not bother me at all. So what we need to know from the medical staff, when we have a death, this is particularly pertaining to the nurses, I would imagine. Sometimes you have to dig a little deep. If someone was septic in a nursing home and had, for instance, bed sores or even pneumonia, we have to dig a little bit deeper. We would like for you to dig a little bit deeper and look into their medical record. We're going to touch a little bit on delayed deaths and how that can be a medical examiner case. But let's just concentrate a minute on the sepsis from the bed sores. Why was that patient in the nursing home in the first place? We may ask you to dig deeper, or it's prudent for you to dig deeper and look and see exactly why that patient was there. If we had a case where someone was injured in a car accident 20 years ago and they fractured the cervical vertebra and were paralyzed, and they've been in the nursing home and they developed the bed sores and the subsequent sepsis or pneumonia and subsequent sepsis and died, does anyone want to venture a guess as to the manner of death that case would be? So that case would actually be an accidental cause of death, because this resulted from an accident a number of years ago that resulted in them being in the nursing home, lying in bed, and developing bed sores. So therefore, if they had not been in that car accident 20 years ago, they would not be in a bed and they would not have developed the bed sores. So we go back that far, that would be an accidental form of death. Where it gets very interesting is issues of an assault that occurred 20 years ago. I know a particular case where a female, her companion had long hair. It was in a ponytail, and they were arguing. I think this particular case was about 15 years ago, and they were arguing, and she grabbed him by his hair and pulled him backward onto the ground. and he suffered a cervical fracture and ended up in a nursing home. So she was convicted of assault, served a sentence for that, but subsequently, as we just spoke about, he developed sepsis and pneumonia from pneumonia and subsequently died. So therefore, uh, that digging back as to why this particular case, why this person was in the situation he was in, that manner of death turned out to be a homicide. Now, of course, that is up to the district attorney whether they want to file further charges, even though this person has served a prison term for the assault. They've not served a prison time um, for homicide. So double jeopardy does not seem to apply in these cases. And it is interesting to see how these are handled by the district attorney. So the cases like that, it is important that we dig back into the records and know why the patient was there in the first place. So you may get an admission to the hospital for the sepsis and the bed sores and may not have access to the records. And that's the EME's job to do that. But we first have to know that it's a potential case. So anytime you can dig further back into the records, that does help us uh, determine the cause and manner of death and whether we need to accept that. Also, frequently we go to scenes. Often we go to scenes of overdoses. We try to go to every homicide and even natural deaths and suicides. We sometimes go to the scene. We don't go to the scene of most motor vehicle accidents simply because we're just a disruption being there. We know what happened and we don't want to cause any delay in opening the highway or assisting the state troopers in opening the highway. Overdoses, often we have delayed deaths where EMS has successfully resuscitated someone. And this is something that the hospital staffs, the ER physicians, the nurses, you can be very beneficial to the medical examiner system. If someone comes in from an overdose death that has been successfully resuscitated, we really need that admission blood. If you could mark that as save the admission blood, we really need that. If it's determined 4 days later that the patient has an anoxic brain injury and the family would like to take them off life support, then that admission blood is what we need. Blood that we take 4 days later may not show up the metabolites of what we want to know in our toxicology reports. So we encourage you, please, if you have overdose deaths that are successfully resuscitated, please make a note that the lab saved that admission blood for us. That is really essential for us to get an accurate toxicology report. What what I want to add to that is some of the cases that are going to autopsy that are mandatory are homicides, overdose deaths by North Carolina statute require an autopsy, but we've had to modify that in a way because of the sheer volume of overdoses that we're having. In North Carolina, we're averaging about 30 overdose deaths a day. And you can imagine the strain that is putting on the medical examiner system. So what we're doing in a lot of cases is our pathologists are examining the body and doing a urine drug analysis. And if the drug analysis is positive for drugs of abuse that would kill them, then and there's no evidence of trauma or suspicion, or law enforcement does not have any suspicion, we will go ahead and forego an autopsy and use the toxicology results. The medical examiner system is very strained now with body storage. I think Raleigh can hold about 150 decedents. We have unclaimed bodies, of course, bodies that are waiting identification. So it is not unusual for Raleigh to exceed that capacity. And if anyone's here from the Mecklenburg office, I'm sure they're well aware of that fact as well. So we'll go ahead to suicides briefly. There are any number of ways, as you all know, for someone to commit suicide. And often it's difficult to know because they're just found deceased and there may be no note present. They may not have indicated anything to family. So this is where we rely on law enforcement and their impressions. We work closely with law enforcement and we often coordinate all of our decisions based on their investigation. In that regard as well, occasionally we have decomposed bodies that are in a residence, and it is impossible to identify these individuals because of the level of decomposition. Often, if the medical examiner and law enforcement agree on strong circumstantial evidence based on that is the individual that is expected to live there, they were in their bed, no one else should be there, their car was in the driveway, then occasionally we do ID people based on strong circumstantial evidence. And that is based on an agreement between law enforcement and the medical examiner. One other thing I wanted to touch on, especially for the ER folks, are hit and run accidents. That is a mandatory autopsy case. As you can imagine, there may be evidence embedded in the body that could help law enforcement solve the case. So what we usually do in a hit and run case is we allow the body to remain in the county for 24 to 48 hours for law enforcement to investigate that case and see if they can identify a suspect. If we identify someone that is charged or admitted to that, then we can go ahead and keep that case without with only an external exam. And I'll touch on that in a moment. And they do not have to go to autopsy. But if you have a hit and run case, immediately notify the medical examiner and they will follow up with law enforcement in regards to whether someone has been apprehended or a suspect has been identified. So just something to remember on the hit and run cases. When we do an exam ourselves, a non-autopsy case, we examine the decedent from head to toe. We have a body diagram that we note just about anything, tattoos, previous surgical scars, And of course, any injuries that we find from traumatic deaths. We may tap into the chest and see if we can obtain, aspirate free blood. That tells us a lot. We can do that in the belly as well. We do a head-to-toe exam, which again goes back to why paramedics, nurses, and the physicians make such excellent medical examiners, because they're familiar with the process. If someone has a bruise on the right upper quadrant, you automatically know that the liver is underneath there. It's a solid organ, and they could very easily bleed out. So that cause of death could be blunt force injury of the abdomen. So once we complete a head-to-toe exam, our samples for toxicology are obtained, and what we obtain is femoral blood. That is our first choice. We like it as far away from the heart as possible. In the old days, some of the older ones among you may remember a medical examiner coming into the ER and sticking a needle directly into the left ventricle. So we found out that that is not the most accurate blood sample to get for toxicology. So we try to get femoral. Our second choice is subclavian. And then we also get vitreous fluid from both eyes. Vitreous fluid is probably our best sample for toxicology. We can obtain vitreous fluid from an embalmed body and still get accurate results. And also you can use vitreous fluid to obtain a blood glucose value. And it's very accurate for that. I have personally determined that someone who was thought to have died of an overdose was actually in ketoacidosis, and that was based on examination and testing of the vitreous fluid. So I want to just bring up an interesting case. I hope there's some discussion here after what we've talked about, and I want to hear your thoughts about this too. I'm sure most of you remember, I think it was probably last winter, but certainly within the last year, when an individual shot up a power substation in Moore County. Does everybody remember that? So I think that made national news. It caused a major problem in Moore County with their power grid for several days. During this time, we had a decedent that was on oxygen therapy, went through all of her spare bottles. Her concentrator, of course, would not work. They had no way to phone anybody. They did not have a generator, and they went through the spare oxygen, and this person died. Just within the last 2 or 3 months, after after the autopsy report was done and so forth, I attended a conference between our forensic pathologist in Raleigh, and there was a lively discussion about whether this should be a homicide or not. So it's not, as you can see, it's not always clearly cut and dry. So in this particular case, the forensic pathologist who performed the autopsy determined, in her opinion, that this was a homicide, that this death would not have occurred had this individual not shot out the power stations. Some of the other pathologists had opposing views, saying this decedent had COPD and that was a natural disease process. So that would have ultimately have killed them anyway. But this was a lively discussion. It was very, very informative to me, and I enjoyed hearing the varied opinions of what that cause and manner of death was. So in a moment when I open up everything for questioning, I hope someone brings that up and we'll ask questions about that. Does anybody have any questions thus far? And I don't, yes, go ahead.
Hey, Jeff, this is John Green. That's a very interesting association, the case you just described. I've been, um, I guess, asked to comment as a expert before, and folks who have died, presumably because of something that happened months or years before. Is there um, I guess, like a statute of limitations or a time limit where you can actually associate a death with an event that maybe somebody was in a car wreck, broke their leg, and then, 2 years later has a PE and died? Is there a legal statute for any time limit in those scenarios?
There is not a legal statute. What our statute is, did the decedent return to their baseline? In your scenario, if the fracture was fixed and he was up walking and was back to normal and was not bedridden or, any of the risk factors for PE, then that most likely, in your opinion, in your medical opinion, would not be caused by the accident of 2 years ago. But there is no statute of limitations. Um, the most well-known and famous case is Christopher Reeve, Superman. I would guess, I'm sorry, I don't know exactly, but I would guess that about 30 years passed the interval between his horse accident and when I think his cause of death was pneumonia, that he became septic and died. So that is the most famous case. There is no statute of limitations there from a medical legal death investigation standpoint. He would not have been in that position if it had not been for his riding accident. So therefore, Christopher Reeve's manner of death would have been an accident. And again, that goes back to, the homicide. Again, you have to think if someone was shot and paralyzed 20 years ago, even though someone served a term for assault, and this person dies from sepsis, it can be related directly back to the gunshot wound, and they can be charged with homicide. Did that answer your question, Dr. Green?
Yeah, it did. Thank you very much.
Okay.
Really interesting.
And forgive me, I don't know the title, but David Jacobs.
Yes, thanks. This is very interesting. In what category would you put medical malpractice? And so we frequently hear on the trauma, not frequently, but we sometimes hear on the trauma service, the lawyers will try to advance a defense that the patient had survivable injuries. Let's say this is a gunshot wound. Patient had survivable injuries, but the doctors botched his surgery, or the doctors didn't provide the care that they were supposed to provide, and that's why the patient died, not because of the patient's injury. So is that something that you all have to get into, or would you just sign that out as a homicide, or even in the setting of a patient who's in a motor vehicle crash and the patient has complications as a result of the care that he was provided? Do you ever sign those out as homicides due to negligent medical care? Thanks.
That is an excellent question. This occurs probably 3 or 4 times a year. So, number one, you are free to reach out to your medical examiner at any point. That is a given. If you have a question, reach out to your local medical examiner. How you do that typically is call 911, the non-emergency number, and ask for the medical examiner on call. Now, this is very interesting. Let's say you had someone who was in a traffic accident who had to go to surgery, but in all likelihood would have survived the surgery given the typical medical care today, and a surgeon accidentally lacerated an artery. That point becomes, it would not likely be an autopsy, but it would likely go down to, we would reach out, the local medical examiner would reach out to our senior forensic pathologist, and everyone has that in their region, several, and we would discuss that case with them. Under your scenario, I think if a surgeon accidentally nicked an artery and caused someone to bleed out before they could control it, that would be an accidental form of death. And that could be included as along with the blunt force injury. Whether or not that is malpractice is for an attorney to decide. But yes, you all have the ability to reach out to your medical examiner for a consultation. And your local medical examiner is not qualified to make that decision. That needs to be decided by a board-certified forensic pathologist. And that person would make that determination and then guide you correspondingly how to handle that particular case. That is a very, very good question. And I can say that most cases where someone dies during surgery, they end up not being medical examiner cases, and that is considered a natural death because death is a reasonable expectation of a surgical procedure. That's the consent forms that people sign. Things can happen during surgery that can cause death, and people sign consent forms for that reason. So typically that is considered a natural death. But now there are instances, again, where something's done during surgery that directly caused the death, like a perforated bowel or as the aforementioned blood vessel. So again, that would be up to the forensic pathologist to determine. And I will say there are regional pathology offices across the state. We have the main one in Raleigh. We have one at ECU. We have one at Wake Forest Baptist, which I think is now affiliated with Atrium, which I think you folks are. And of course, we have the Mecklenburg County Medical Examiner's office in Charlotte. And all you need to do is reach out to your local medical examiner or your regional office, which would be Charlotte, and they would give you guidance on that particular kind of case. But that is a very, very good question. If there is gross negligence that caused the death, yes, that may be included in the cause, but that would be with consultation with the forensic pathologist. Freeman. Please go ahead with your question. Elizabeth.
Yes, thank you very much. My question is somewhat similar to Dr. Jacobs. As trauma centers, our regulatory bodies expect us, if we have an unexpected death, that we need to find the cause of death. And however, like if we have, let's say, a 70-year-old fall that's here, no real significant injuries, but has an inpatient event that causes a sudden death. Or let's say we have a patient, 50, 60-year-old with rib fractures. Most patients don't die from rib fractures, but they have an inpatient event that causes a rapid death. We have difficulty getting past our local MEs to try to get an autopsy because they are told that is essentially a natural death from blunt trauma, but they don't see the need for an autopsy like we from the trauma standpoint do. Can you help with understanding that better?
Oh, I will certainly try. Number one, I can tell you, I see elderly people die of rib fractures all the time simply because they can't perform deep inspiration due to the pain, and they develop lung problems for that. So that certainly well could be. I've seen numerous death certificates with complications of multiple rib fractures, even if they did not have a pneumothorax. I understand that you're wanting to know why an autopsy is not performed. And I kind of go back to the volume that we have, but also with a careful understanding of the history of this current event. An injury occurred, and that is likely the cause of death. You do see it more in hip fractures. We all know, 80-year-old people that contract hip fractures, often do not survive them. So we would not learn anything at autopsy by performing one. We would just know that there was a hip fracture, and they ultimately declined and had organ failure. So we're not going to learn anything by doing an autopsy, and that's why they're declined. Does that answer your question, or do I need to what?
Yeah, somewhat. I guess you're coming from it from a different angle than we are. So for a 60-year-old with 3 or 4 rib fractures, for us, the vast majority of those people survive and do well. So I do agree that you probably see deaths due to rib fractures. I guess from our standpoint on the patterns of injuries that most survive on, and then we have a sudden death that we cannot explain. Again, we are expected to kind of know the cause of death, but when we go to pursue it, that's kind of where we meet roadblocks. And I do understand it's a volume issue. You have things that have to have autopsies, and it's kind of conflicting with our trauma expectations, I guess. Dr. Jacobs, can you articulate that any better than what I'm trying to do?
No, I think the college is primarily concerned with preventability and whether there's something that we as a trauma system did or trauma center did that did or did not contribute to the overall outcome of that patient. So, yeah,
so this is a trauma registry type issue, correct?
So I can speak to this a little bit. Hi, I'm Tracy Henry. I'm actually one of the medical examiners for Mecklenburg County. And so I have asked this question many times actually from the pathologist. And so there's a big difference between a medical autopsy to find out what happened in an unexplained event that happens within the hospital and an investigative autopsy that would be done by the medical examiner's office. When you have a patient that has a sudden death in the hospital, whether it's trauma or not, if you feel it was an unexpected death that needs an explanation, that's actually when you should try and order a hospital autopsy. They always give a lot of pushback because the pathologists in the hospital generally don't do a lot of autopsies, and they do communicate with the medical examiner's office to make decisions about that. And usually the medical examiner's office will go ahead and give them jurisdiction to do an autopsy in the hospital. But that's really the big difference, is if you're looking for a cause of death for a patient that had an inpatient event, you really need to do a medical autopsy. The role of the medical examiner's office in autopsies is to do investigative. Usually that means homicide, anything that's likely going to go to court. We've had a couple of them that have gone through pretty well. We've had a couple, well, I know of a few cases where we've had trauma patients that ended up dying from infection that was actually unrelated to their trauma. And so those generally go for medical autopsy. And if you do get pushback from either, so the other part to look at is when they're filling out the form at the end that says, is an autopsy requested, you do have to get family permission for a medical autopsy in the hospital. And oftentimes that part of the form is not filled out by the family. So if you're looking for causes of death for something that happened inpatient that's unexplained, medical autopsy should be the route that you go. And that should be done by your actual hospital pathologist. Hopefully that'll clear things up and add a little more understanding to the difference.
Yes, that was helpful. Thank you, Tracy. Appreciate that.
I think that was very elegant, Tracy. I didn't see you were there. Tracy was one of my students fairly recently in our ME class, and that was very eloquent and well put. So I do appreciate that. And we do realize that the trauma centers have trauma registries and trauma registrars that have to note these things. And that was some very valuable advice that the medical examiner's office is always willing to consult and work with you on those type of issues. Now, I notice we're running about 10 minutes left. I don't know if anybody else has any questions, but I'll open the floor up and I will be happy to answer them. And I will reiterate, it was a pleasure to be here today. I hope I gave you some thought-provoking information and some information that will help you in your day-to-day practice about what could be a medical examiner case that might slip through the crack. Again, we are always actively recruiting. Please get in touch with me if you are interested. And we have a 4-day class that's medical examiner orientation. The class starts out with all the rules and legislation that affects medical examiners. And then it goes all the way into identifying gunshot wounds, stab wounds, all the way through our exam of the body. And once that 4-day class is concluded, you spend a half day conducting an actual case with one of the trainers, such as myself. Charlotte has, that area has the volume where I'm sure they could hold a case. And we could come in and do the training, or I live in Hendersonville, the Asheville area, and I always can get a case here in the Buncombe County area to do training. So again, please send, Scott will give you my email address, and please feel free to reach out to me. And now I will take any questions. And I see one question or one hand raised, I believe. It's under participants, so I can't see who it is.
Dawn Middleton is next.
Okay, Dawn, please
Hi.
go ahead. Hello,
Hi.
it's a pleasure to talk to you.
So many questions, but I'm going to limit it just to one. So in the emergency department, when trying to figure out if families can see their deceased patients or their deceased family members when they are medical examiner cases, if it's, obviously if it's a violent homicide or suspected homicide or something like that, we always defer to law enforcement and just go off of what they tell us. But curious here lately, have been told that the family shouldn't see their loved ones if it is a medical examiner case and it's like, say it's determined it's not a homicide, and that they would appreciate the families just to wait till they get to the funeral home from the ME's office. Is there we just need to know what to tell them. So is there a rule on that, would you say?
The specific policy is, if it's a medical examiner case, no. But there's also the human compassion involved. If a 90-year-old broke her hip and died in the ER, what is the value of preventing a family member from seeing that decedent? There is none. There's no evidence that's going to be tampered with. We just expect everyone to be prudent and use good common sense. I am often asked about infants, sudden infant death. We really don't like the parents to hold the baby, but they can certainly be right there, and touch the baby's hand and so forth. Our one absolute is no one is to be left alone with a decedent that may have potential evidence on them, like a homicide or the infant. If the parent wants to sit by the baby and hold its hand, we have to have a measure of compassion. But as long as they're not alone with the decedent, then most pathologists are comfortable with that. Does that answer your question? Use common sense.
It does. Thank you very much. And like I said, I have so many questions, but I'm going to get your information from Scott and reach out. Thank you for your lecture today.
Oh, you're more than welcome. I'm happy to be here. Do we have any more questions?
Hey, Jeff, I have one real quick. Very interesting talk. Thank you.
You're welcome.
Some programs, it's not a huge thing, but some programs are either using or entertaining the idea of doing post-mortem CTs to gain more information about what was going on inside the body at time of death. Have you heard of this? Do you feel that, if you are familiar with it, is it a useful tool for as part of your investigation? Just curious about your general thoughts about it.
It is very useful to me. However, if it's an autopsy case, we do a full body scan as soon as they arrive at the autopsy facility. If you have an unexplained death that you determine, as Tracy mentioned, that is not going to be a medical examiner case, then I see no reason why you could not do a full body scan to help you in determining a cause of death. I don't see any problem with that whatsoever.
Thank you.
So we have started our we've tried to start our postmortem CT program here at Atrium Health, and we're currently just waiting for some of the logistics for payment for radiology and stuff to get worked out still. But we did have one that went through postmortem CT, and I will tell you that from the medical examiner's perspective, it caught an occipital atlanto disassociation, and that is an injury that the pathologist said they never would have been able to see on autopsy. So for them, they're very interested in the program because they're very interested in seeing what might come up that they would never be able to see on autopsy. they usually can see things like ruptured, large ruptured vessels, that kind of stuff they can usually see. But for them, that was actually an injury. That particular case was a pedestrian struck. And so that was actually very helpful for them. And it actually changed what they wrote on the death certificate. So we're pretty excited about it.
And I would be too. I would encourage you to reach out to Dr. Prevet about that and, have a policy in place and get the input from the forensic pathologist. I think that's very helpful. I know that I've had intraoral gunshot wounds that I could put a probe in and not find the entrance wound. And, I've got long fingers, but I couldn't find it. And I have actually asked the x-ray department to come down and take an x-ray, and then I could identify where that occurred. So I can see where this is certainly beneficial. I would be all for it. I wouldn't, I would just, I would use one of the pathologists as a consultant for your policy. I think that's a wonderful idea.
All right, are there any other questions?
Well, it's been a pleasure to speak with you all today. I think I've taken up your hour. I hope I've given you a little bit of information as to the understanding of the ME system and how it works and how we, as medical professionals, work together to help each other. But if you take away one thing from today, please know to reach out. If you have any questions, any medical examiner will be happy to answer your questions. Charlotte does fall in my region, so I am always open to questions. And Scott, can you type something in? Well, I don't have my chat pulled up, but
Yes, go ahead.
I'm going to give you my personal cell phone number. Everybody else in the state has it, so there's no reason you shouldn't either. It's area code 336-267-8498. And that is my personal cell phone number, Jeffrey Leach. And again, Mecklenburg County is my region, and I will be happy to answer any question at any time. And if I don't know the answer, I'll certainly consult with the forensic pathologist and get an answer for you. It's been a pleasure, and I thank you very much for having me today. It's a pleasure to speak with you all. And nice to see you again, Tracy.